I am Dr. Jeevana Nilkund, and I will be talking on aplastic anemia and splenomegaly. Before going into the aplastic anemia proper, let us see one or two case scenarios where it is leading on to decrease in all the cell lines. So here we have a 24-year-old female patient admitted to the hospital with symptoms of weakness, shortness of breath, fever, and recurrent nosebleeds. The laboratory test showed hemoglobin is reduced to 3 grams per cent. WBC is reduced to 1,500 cells per cubic millimeter. Platelets are reduced to 15,000 cells per cubic millimeter. And a bone marrow examination was found to be hypocellular marrow with few hematopoietic cells. So this is one case scenario where all the three cell lines are reduced and the bone marrow is hypocellular. The second case scenario is a 15-year-old boy. He is supposed to be on a vegetarian diet and he comes with symptoms of he is given the investigations which indicate that the hemoglobin has reduced. It is 5 and the mean corpuscular volume is 116 femtoliters. The WBC count is 2000 cells per cubic millimeter. Platelets are 50,000 cells per cubic millimeter. And there is also icterus secondary to hemolysis and splenomegaly. So in both these cases, we have there is a reduction in RBC, WBC, and platelets. So all the three cell lines decrease. We call it as pancytopenia. Pan means all, and cytopenia is a reduction in all the three cell lines. So why are we dealing with pancytopenia in aplastic anemia? Because aplastic anemia is one of the causes for pancytopenia. So causes of pancytopenia, we have bone marrow aplasia or hypoplasia as one of the causes for pancytopenia. And this is followed by other causes of bone marrow necrosis, bone marrow fibrosis or sclerosis, and myelodysplasia or myelophthisis, where there is, in all these conditions, there is a decreased hematopoietic cell production. And in some cases of increased hematopoietic cell production, also we do see pancytopenia. Among the cases of pancytopenia, we have the leading cause as megaloblastic anemia, followed by acute myeloid leukemia and aplastic anemia. So now we dealt with pancytopenia. Under that, we have causes of pancytopenia where all the three cell lines reduced, and in that we have aplastic anemia. So we are dealing with aplastic anemia. So the first feature of aplastic anemia is pancytopenia. That means it is a syndrome of bone marrow failure. So there is decrease in all the three cell lines leading on to anemia, thrombocytopenia, and neutropenia. There is a suppression or disappearance of the multipotent stem cells. So there are no stem cells or there are reduced stem cells leading on to decrease in the reduction of these hematopoietic cells. Now, as we all know, the stem cells are of two types. Either they are pluripotent stem cells or they are differentiated stem cells. So there might be a decrease in any of these stem cells, either pluripotent stem cell or erythroid committed stem cell. What are the causes for stem cell failure? So stem cell failure can be because of radiation. It may be because of viruses, parvovirus, hepatitis, non-A, non-B, or Epstein-Barr virus. It may be because of the drugs. So either the chemotherapeutic agents that we use, mainly these alkylating agents, etc., or antimetabolites, phenylbutazone, identoin, etc., to name a few of the drugs that cause stem cell failure. It may be chemicals or toxins leading on to stem cell failure in the form of benzene, weed killers, insecticides, or arsenic. It may also be the stem cell failure may be due to immune disorders, of which it may be SLE may be an example. So wherever there is a stem cell failure, the cause may be either in the form of radiation, viruses, or drugs, chemicals, or immune disorders. After knowing causes for pancytopenia, the same applies to aplastic anemia. What is the etiology for aplastic anemia? It can be inherited or it can be acquired. Under inherited, we have Fanconi's anemia, and in acquired, we have the similar causes for pancytopenia. So it may be idiopathic, where the cause is not known, and it will affect the primary stem cell. So it may be a primary stem cell defect or it may be immune mediated, but the cause is not known. And the second one can be chemicals, any of those chemicals, either cancer chemotherapeutic drugs or even other drugs like chloramphenicol, phenylbutazone, which cause suppression of the bone marrow. Physical agents in the form of whole body radiation, so it may be because of therapeutic radiation or an occupational hazard where the whole body is exposed for radioactive agents and radioactive substances leading on to suppression of a bone marrow. The fourth cause would be viral infections, mainly the cytomegalovirus, Epstein-Barr virus, or the herpes and hepatitis virus. So under etiology, we have inherited and acquired. Inherited is Fanconi's anemia and acquired again idiopathic, chemical agents, physical agents, or viral causes. Now, how exactly this stem cell disorder is going to manifest in the form of aplastic anemia? So the stem cell is in fact is being affected by the viruses, drugs, etc. Whatever the insult on the stem cell will lead on to alteration in the stem cells. So the stem cells will lead on to go on to express new antigens, and these antigens will elicit a T cell response, which in turn will bring about the marrow aplasia, or they by themselves will bring about a reduced proliferative and differentiative capacity to the stem cells. So whatever the viruses, drugs, chemicals, etc., bring about a change in the stem cell, and they cause the reduction in the proliferative and differentiative capacity. So the stem cells, they cause injury. The stem cells are injured because of the virus, drugs, chemicals, etc. They become genetically altered. They secrete new antigens. And because of the new antigens, they elicit a T cell response, which causes marrow aplasia, or they directly reduce the proliferation and differentiation of the stem cells, thereby causing marrow aplasia. Coming to morphological findings in case of aplastic anemia. So how do we diagnose aplastic anemia? So whenever we suspect a patient, we send the complete blood count. So when a complete blood count is done, there is decrease in all the three cell lines, that is WBC, RBC, and platelets. So RBC count reduction is seen in the form of the decreased hemoglobin. There is a decrease in the WBC count, there is a decrease in the platelet count, and a decrease in the reticulocyte count. So reticulocyte is, you all know, it is a cell that is the precursor of a mature RBC. So if the reticulocyte count is normal or more, it indicates that there is erythropoietic activity that is going on. So reticulocyte count is low, that means there is no marrow activity. So the marrow is suppressed or it is not functioning. So the reticulocyte count normal is 0.5 to 2.5%, whereas in case of aplastic anemia, it will be reduced. If we look at the peripheral picture of the case of aplastic anemia, we need to see the RBCs. The RBCs are normocytic, normochromic. So they are normal in size and the chromasia is normal. So the MCB is normal, MCH is normal. So this is a type of normocytic, normochromic anemia. A bone marrow aspirate is done, it yields in a dry tap. So we do not get any material or only blood. Next is to go for a bone marrow biopsy. So a bone marrow biopsy is again hypocellular. So indicating there are more fat spaces and lymphocytic infiltration, and there is a reduction in the hematopoietic cells. So we have a condition where all the cell lines are reduced. There is reduction in the reticulocytes. There is normocytic, normochromic type of RBCs. There is a dry tap on a bone marrow aspirate, and the biopsy will yield hypocellular marrow. This is how the peripheral smear looks like in case of aplastic anemia. So the cells are all normocytic, normochromic with mild anisocytosis, and there is reduction in WBCs as well as platelets. If we take a picture of this bone marrow biopsy, the normal biopsy would indicate that there are 75% of it is showing the hematopoietic cells, and only a less percentage of 25% or less is the fat cells. So these clear spaces are all the fat cells. Whereas in case of a aplastic anemia, we see that there is more number of fat spaces and there are hardly any cellular elements that are seen. So these are the bony trabeculae, and these empty spaces are all fat cells, and the smaller things that are seen are the hematopoietic cells. So if we take this in a bigger magnification, these empty spaces are all the fat cells, and these small cells are mainly lymphocytic cells. So in general, all the cell lines are reduced and we are seeing mainly the lymphocytes. This is a case of aplastic anemia where the bone marrow is hypoplastic. So coming to the clinical course, we do see this condition at any age, in any age group, and it is seen in both the sexes. It has got a insidious onset, so it goes on for some time till the patient manifests. So the RBCs, WBCs, and platelets all have to be reduced beyond the normal, and then the patients will show signs and symptoms of anemia, thrombocytopenia, and neutropenia. So patient will complain of weakness, dizziness, breathlessness because of anemia. Thrombocytopenia, the patient may complain of hemorrhage. So the patient bleeds from trivial sites or very easy bleeds because there is reduction in the platelets. And because of neutropenia or leukopenia, there is increased risk of infection. Thereby, the patient comes with a history of fever. What happens to the spleen? Spleen is not enlarged. So, in case of aplastic anemia, there are several ways of grading it, and the severity is more when the marrow cellularity is less than 25%, the absolute reticulocyte count is less than 40%, platelets is less than, absolute reticulocyte count is less than 40,000, platelets less than 20,000, and the granulocyte count is less than 500 cells per cubic millimeter. What are the differential diagnoses in case of aplastic anemia? All the causes for pancytopenia are the differential diagnosis for aplastic anemia. So it may be paroxysmal nocturnal hemoglobinuria, it may be myelodysplasia, acute leukemia, megaloblastic anemia, or hypersplenism. In hypersplenism, it is a little different than the others, that there is pancytopenia, but the marrow is hyperplastic. What happens to these cases? What is the treatment and what is the prognosis? The prognosis is not very good if it is of unknown etiology. If it is of a known etiology, as with toxic drugs, withdrawal of these toxic drugs will lead on to recovery of the patient. Whereas if the condition is idiopathic, spontaneous remissions, etc., are very, very uncommon. So we cannot treat the patient. If the patient is very young, the other possibility is allogenic bone marrow transplantation, which will replace the stem cells and then the bone marrow will rejuvenate. And if it is an older patient, immunosuppressive therapy can be thought about. So in summary, aplastic anemia is because of bone marrow suppression, and this bone marrow suppression is seen in the form of pancytopenia, that is reduction in all the cell lines, RBC, WBC, and platelets, and it is manifested in the form of anemia, that is the patient complains of weakness, breathlessness, etc. Because of thrombocytopenia, there is bleeding, and because of neutropenia, there is infection. And the causes, it may be idiopathic, where the cause is not known. It may be secondary to drugs. It may be secondary to viruses, and it can be due to radiation. So radiation can be therapeutic or an occupational exposure. The bone marrow aspiration is usually a dry tap, and we need to do a bone marrow biopsy. So a bone marrow biopsy is most of the time hypocellular. Next is the spleen. Spleen is a largest reticuloendothelial organ in the body, intra-abdominally placed, and it is a wedge-shaped organ. It is seen in the left hypochondrium and in the epigastrium. It is soft and highly vascular organ. As you all know, it has got variable size and weight, varying from these are the average size and weight. Average size is easy to remember, 1 inch in thickness, 3 inches in width, and 9 inches long, and it is a wedge-shaped, convex-shaped organ, and it's about 150 to 230 grams by weight. It derives most of the blood supply from the splenic artery, a small amount from the short gastric vessels, and drainage of this is mainly into the splenic vein. Now, what is the function of the spleen? So, as you all know, physiologically, it is involved in the filtration process where it removes all the RBCs which are not normal. It removes all the WBCs, etc., that are not normal. It is involved in the host defense. Being a reticuloendothelial organ, it has got lymphoid follicles, and it is a site of lymphocytes, so it is involved in the host defense. It is seen as a storage organ, and it is seen in the form of extramedullary hematopoiesis. So you know that liver and spleen are sites of hematopoiesis. Before the bone marrow takes over, the hematopoiesis occurs in the liver and the spleen. So these are the functions. So it is involved in filtration, host defense, storage, and hematopoiesis. What are the anomalies that we see in the spleen? There might be a complete absence of spleen, which is very rare. It is most of the time associated with other abnormalities like situs inversus. There might be hypoplasia of the spleen, which is more common. But the most common condition is having accessory spleens. So generally, they are in the gastrosplenic ligament or near the tail of pancreas or in the omentum or in the mesentery. So importance of accessory spleen is whenever splenectomy is done, if the accessory spleen is not looked for, the patient may not get benefit of splenectomy. So does the spleen enlarge? Yes, enlargement of the spleen is called as splenomegaly. And is it always palpable? As such, spleen is not palpable. And for the spleen to become palpable, it has to enlarge at least 2 times its normal size to become detectable, or else the spleen is not palpable. And it enlarges from the left hypochondrium towards the umbilicus and into the right iliac fossa. So to become palpable, it has to be enlarged twice the size, and it enlarges from the left hypochondrium towards the right iliac fossa. So it enlarges from the left hypochondrium towards the umbilicus and into the right iliac fossa. This picture shows how to palpate the spleen. Put the patient in a supine posture, elevate the spleen from the back side, and then palpate with the left hand should be on the back and lift the spleen, and the right hand should palpate below the left hypochondrium. Or you can put the patient also in a right lateral position and palpate below the left costal margin. There are other methods as well related to percussion and find out the spleen. These are few methods of percussion and related to the tracing of the spleen. Now, spleen can be enlarged and it has been classified based on the size, based on its extent below the costal margin. It is called mild splenomegaly if the spleen is less than 5 centimeters in the costal margin. If it is between 5 and 8 centimeters, it is moderate splenomegaly. Whereas if it exceeds 8 centimeters, it is severe splenomegaly. So we have splenomegaly, which is classified into mild, moderate, and severe. Less than 5 is mild, 5 to 8 is moderate, and more than 8 is 8 centimeters is severe splenomegaly. This is in the costal margin. There is one more way of grading it. If it is not palpable, it is 0. So I said spleen should be at least twice the size of its normal size to become palpable. So if it is not palpable, it is graded 0. If it is palpable on deep inspiration, it is grade 1. It is grade 2 if it is midway between the umbilicus and the costal margin. It is graded 3 at the umbilicus. It is graded 4 if it is just below the umbilicus, and beyond that, up to the pubic symphysis, it is graded 5. So we have 5 grades from not palpable spleen, palpable on deep inspiration, up to the umbilicus, below the umbilicus, and into the pubic symphysis. What are the conditions that lead to splenomegaly? So splenomegaly may be because of increased function, abnormal blood flow, and infiltration. So splenomegaly is because of increased function, abnormal blood flow, and infiltration. Increased function may be because of the related to the RBCs. So removal of defective RBCs is the function of the spleen. So if it has to remove more number of defective RBCs, it will cause splenomegaly. as in conditions of spherocytosis, thalassemia, hemoglobinopathies, nutritional anemia. So there is increase in the defective RBCs, so the spleen function has increased. As in case of infection, so it is involved in the immune function as well. So there is increased infection will lead to splenomegaly. So it may be infection with viral, bacterial, fungal, parasitic, etc. It may be subacute bacterial endocarditis or bacterial septicemia. There may be splenic abscess. It may be histoplasmosis or any of these malaria, leishmania, or trypanosomiasis. So any infections for that matter will lead on to splenomegaly. Also the immune dysregulation. So disordered immune dysregulation. If there is rheumatoid arthritis, SLE, serum sickness, autoimmune hemolytic anemia, sarcoidosis, these are all related to immune disorders may lead on to splenomegaly. As I said, spleen is a site of extramedullary hematopoiesis. So whenever there is no functioning bone marrow, the body tries to compensate by extramedullary hematopoiesis in the form of, so in conditions like myelofibrosis or marrow is infiltrated by tumors, leukemias, or the marrow is damaged by radiation or toxins, so the marrow is not functioning and the spleen tries to compensate. It is called as extramedullary hematopoiesis, and in those conditions, the spleen is enlarged. Increase in the blood flow. So whenever there is organ failure like cirrhosis, there is liver failure leading on to portal hypertension and obstruction of the splenic vein, and this leads on to increased blood flow. Similarly, vascular increased blood flow or obstruction in the form of hepatic vein obstruction, portal vein obstruction, Budd-Chiari syndrome, or a splenic vein obstruction for any reason will not allow the outflow of blood from the spleen away from it. So there is splenomegaly. There may be splenomegaly because of infiltration. So there will be the storage disorders or metabolic disorders like Gaucher's, Niemann-Pick's, Hurler syndrome, or mucopolysaccharidosis, where these macrophages are seen along with this disorder, where there is the accumulation of the substrate because of enzyme deficiencies. Amyloidosis is one where there is deposition of amyloid into the spleen. Again, it may be either a large spleen where amyloid is deposited in the red pulp, or sagospleen where it is deposited in the white pulp. The last one is infiltration. So it may be something infiltrating into the spleen, causing the spleen to enlarge. So it may be leukemias, lymphomas, myeloproliferative disease, metastatic tumors, or benign tumors like meningioma, lymphangioma. It may be cyst in the spleen or hamartomas leading on to splenomegaly. So mild splenomegaly is seen in case of malaria, typhoid, TB, viral hepatitis, septicemia, etc. Moderate, that is 5 to 8 centimeter spleen or up to the umbilicus in case of cirrhosis, lymphoma, leukemia, infectious mononucleosis, hemolytic anemia, splenic abscess, amyloidosis. Severe splenomegaly, please remember these few conditions of severe splenomegaly. It may be chronic malaria, Kala-Azar, CML, portal hypertension, thalassemia major, or infiltrative and metabolic disorders leading on to severe splenomegaly. Management depends on the cause and investigations, right from blood test to the complete blood test to the CT. Treatment can be medical or surgical based on the cause. Medical management involves treatment of the cause if possible. Surgical treatment is splenectomy. Indications for splenectomy commonly are trauma where there is splenic rupture. It may be ITP, hemolytic anemias to relieve the destruction of the RBCs and the platelets, and CLL or chronic lymphocytic leukemia, lymphomas, myelofibrosis, or tropical splenomegaly. So with this, we conclude the topic of aplastic anemia. What are the different causes for aplastic anemia, and about splenomegaly? What is the normal spleen when it is enlarged? What is splenomegaly? What are the grades of splenomegaly? And what are the causes for splenomegaly? My references have been from textbook of pathology Harsh Mohan, Robbins, and Potron, pathologic basis of disease, and internet sources. Thank you.